Good afternoon, everyone. So today I will be discussing about management and outcomes of manual small incision cataract surgery in cataract with corneal opacity. The authors have no financial interest to disclose. Cataract is the leading cause of blindness in India, followed by corneal opacity. The opacity will limit the surgical field by hampering the visualization of intraocular structures, thus posing various challenges like increased risk of incomplete capsulorhexis, retained risk of cortex, and posterior capsular rent. The advantages of MSICS over phaco include easier to perform procedures like sphincterotomy, optical iridectomy, managing without a complete capsulorhexis, apart from being affordable and cost-effective. So the aim of the study was to evaluate intraoperative management of cataract with corneal opacity and to report the outcomes of the surgery done in patients with corneal opacity. So we did a retrospective study and included 286 patients having cataract with a pre-existing corneal opacity who underwent MSICS during a study period of 2 years. The pre-operative findings were noted, corneal opacity findings were noted, and the corneal opacity was classified according to the Agrawal classification into nebular, macular, leukomatous, and adherent leukomatous opacity. We did a pre-operative A scan using IOL Master 700. In patients with dense media opacities, immersion biometry was used. In patients where the keratometry reading could not be obtained due to irregular corneal Meyers, other eye keratometry reading was used. When both eye keratometry reading was not obtained, an arbitrary K reading of 44 and 45 diopter was used. MSICS was done under subtenous anesthesia. Intraoperative complications, BCVA, anterior and posterior segment examination was noted on day 1 and day 30. We had done certain procedural changes for these patients, like making the corneoscleral tunnel on the steeper meridian for all patients. For pupillary dilatation, we had used intracameral adrenaline, multiple sphincterotomy, stretch pupilloplasty, and iris hooks were used. Optical iridectomy was done in some patients. The anterior capsule was stained with tryphan blue dye, and rhexis was done under retroillumination. Coming to the results, the most common type of corneal opacity was nebular opacity, the etiology being trauma and followed by viral and fungal keratitis. Most of the opacities were either centrally or paracentrally located. For the intraoperative management, 33 patients underwent multiple sphincterotomy. Capsular tension ring was used in 4 patients. Optical iridectomy, iris hooks, and stretch pupilloplasty was done in some patients. Coming to the intraoperative complications, the rate was 4.89%, amongst which PCR was seen in 7 patients, zonular dialysis was seen in 2 patients. 2 patients had whole bag removal who were managed consecutively by placing a scleral fixated IOL. Iridodialysis and Descemet membrane detachment was also seen. The day 1 post-op complications were like iritis, corneal edema, blood clot in anterior chamber, and they were managed medically. There were 3 patients having retained cortex in the anterior chamber, and the post-op complications on day 30 included minimal residual cortex and 6 patients having mild descent at IOL. So the mean logMAR BCVA improved from 1.08 preoperatively to 0.30 post-operatively at 1 month. 88.5% of our patients were having a BCVA more than 618 at 1 month follow-up visit. So cataract with corneal opacity reduces the intraoperative view during surgery, leading to higher chances of complications. But owing to the lesser availability of good quality of donor corneas, the risk of graft rejection, and the need for meticulous post-operative follow-up, it is often difficult to carry out a triple procedure in many patients of the developing countries. So MSICS can be done in these patients. To conclude, MSICS is a safe and feasible therapeutic procedure in providing ambulatory vision in cataract patients having pre-existing corneal opacity. These are my references. Thank you. Ma'am, actually, because of the corneal opacity, we had done the sphincterotomy only in the area where we needed a better visualization. So, and some patients were having small pupil. And apart from that, for the corneal opacity itself was covering a larger area. So we had to do sphincterotomy in order to have a good visualization, especially for rhexis and the cortex removal.
Pupillary dilatation was not adequate in those patients?
In some patients, yes, ma'am. A major reason was because of the corneal opacity, ma'am.
Majority of your cases had central corneal opacity?
Yes, ma'am. Either central or paracentral opacities, ma'am.